This week on The Futurists, Suneel Ratan.
I think we have to, part of this is kind of how do we enable or leverage AI to kind of infuse things like trust and compassion back into our system. So it isn't about process or profit or all of that all the time, because I think it's depressing.
Hey there, welcome back to The Futurists. I'm Rob Tersick, and with me this week is my buddy and co-host, Brett.
Hey.
Hi, Brett. So you're now in Brazil.
Yes, I'm in Brazil for a few more days, and then next time we do a recording, I probably will be in Melbourne, Australia. I'm going to go see my dad for the end of the year. So,
Wow. You know, you're like a living example of the William Gibson thing. If you want to see the future's unevenly distributed. So you have to kind of go around the world to see glimpses of the future. And
it's true.
I love it because you get the wear and tear and I don't. So I'm not the guy with the
No, I think you were going to say a living representation of the carbon output problem, but which would also be fair, frankly.
Yeah, that's right. We'll be buying carbon offsets for Brett's flight.
Oh, yes. No, I used my airline miles for carbon offsets, so that's my strategy. But
Okay.
yeah.
Good. You can sleep a little more soundly at night knowing that you gave away a virtual currency to solve a problem. Okay, so listen, this is a topic that's burning here in the United States right now because through basically congressional ineptitude and our unwillingness of our Congress to take any kind of futuristic action, we've reached a point now where the Affordable Care Act, popularly known as Obamacare in the United States, is collapsing. The government in the past year has slashed the subsidies that made that care affordable for more than 20 million people. And now Americans are going to experience skyrocketing premiums. The forecast is pretty dire. According to the Wall Street Journal, healthcare coverage for a family of four will exceed $27,000. By other estimates, the annual premiums could be higher than $35,000 for a family of four. I'm experiencing this myself personally. My own personal premiums now exceed about $12,000 or $15,000, so it's in that range. I'll find out shortly. This is a lot of money to pay for healthcare. Remember, that's just the premiums. Then there's the copay and the minimums that you have to pay alongside it. So, you know, certainly if you use the service, it's going to cost you a lot more than that because you have to pay for every service. So we have this system in the United States that emerged from Obamacare called managed care. And the idea is that an individual person talking to their healthcare provider or clinician is unable to come to an economically acceptable decision about how to get care. And so we need a middleman of some sort to enter the fray. The conservatives in the United States don't want that middleman to be government because they consider that rationing. You may remember Sarah Palin and death panels in a few elections ago, where she raised the specter of, you know, some government appointed bureaucrats deciding who got care and who didn't. But it does seem that American conservatives are perfectly happy to let the private sector make that decision. All healthcare is rationed, and in the United States, managed care means that a private corporation is going to decide whether or not you get the care that you need or the care that your doctor prescribes. Private market, free market evangelists love this principle, but the reality of it is that those companies have to make a profit. And so traditionally what we're seeing in the last 15 years is that more and more claims are being denied. Companies like United Healthcare are kind of famous for denying about 20 to 30% of the claims. So you have to fight really hard to get the coverage that you need. The coverage that your doctor recommends isn't always granted. I'm going into this length because I have many friends and followers in Europe and in other countries outside the United States. And candidly, they are mystified by American healthcare because they don't understand how you can pay for a service, how we pay more than any other country in the world for healthcare. And yet we get less coverage and we have to fight for every single procedure, every single thing that we get. And this is going to get worse. When I worked for Oprah, I worked with Dr. Mehmet Oz. And at the time, he was a rational and I thought smart and well-minded fellow. He's turned into a rabid populist. He's working for President Trump now in Health and Human Services. And he's now come out strongly in favor of more pre-authorizations. And for folks who don't know what that term means, pre-authorization means that you might need a medical procedure, you might even need emergency services, but you have to get permission from some bureaucrat in a healthcare company before they can proceed by giving you the care. You have to actually get your surgeries and procedures approved in advance. And this is meant to be a measure to kind of control overconsumption. But it's just a form of privatized rationing that happens. And now Mehmet Oz is advocating that we expand that across the board for Medicare, for the senior services. So that's the state of America right now. 20% of the US economy consists of healthcare, and yet our country has worse healthcare outcomes than most industrial economies. And here to talk about all of that is our guest this week, Suneel Ratan. Suneel, what a setup. I'm just setting like a bear trap for you to walk right into. Suneel's an old friend of mine. What were you doing when we last spoke?
I think I had just started at a so-called remote patient monitoring company called Health Hero Network, and we met through our mutual friend Peter Marks, right?
Yeah.
Yeah.
Oh, okay. So you've been in the healthcare field for some time, but now you're doing Precognitive and you're doing AI.
Yeah, we're doing Precognitive.
Okay, so tell me, what problem is Precognitive trying to solve?
Well, if you step back, okay, so you're asking like, why is U.S. healthcare so expensive?
Mhm.
So one of the reasons it's so expensive is that the system is horribly fragmented and siloed, right? And it's gotten much, much worse with the advent of information technology. And as we get into talking about Precognitive, it's basically a way to think about what we're doing is applying fintech, right, to healthcare and social services infrastructure. So the system is horribly fragmented. And then, I think what you're getting at is that, the system tries to manage the utilization of the average person
Mhm.
when most healthcare, or when about 5% of the population choose through 50% of the cost, right? Pure Pareto principle. So the system by and large, so over the last 20 years, so managed care actually goes back to the mid 1990s. It was really born in California. I mean, even stepping back further from there, Kaiser Permanente is, essentially a managed care plan that is mated to an integrated healthcare delivery system.
I'm a recovering victim of Kaiser Permanente's so-called
But
services.
at least your care was reasonably coherent because they all, among other
Yeah.
things, were operating off the same.
It's easier to use if you can get a doctor's appointment, and often you can't.
Right, because rationing.
Yeah.
Right, that's not an infinite resource. So you got horrible fragmentation. Managed care tries to manage the utilization of the average person when cost is really concentrated in about 18 million Americans. Right, 18 million Americans chew through about 50 or $2.5 trillion worth of cost. Those people tend to be socially and medically complex. One of the reasons why your healthcare costs so much is that the government, okay, a lot of those people are concentrated in the government programs, Medicare and Medicaid. And Medicare and Medicaid do not pay cost, right? So if you're a hospital system in California, for instance, a nonprofit delivery system like Sutter Health or, down in Los Angeles, Providence, right? Or, they get paid on average for a Medicaid patient 70 cents on the dollar, maybe 65, 70 cents on a dollar. They got to make up that money some way. So they do it by then negotiating much higher rates with the plans that cover us. Right. So way to think about it is that Medicare
Like a cross subsidy from the people who are not on the government programs. So our premiums that we pay in private healthcare are subsidizing the public program.
Yeah, because Medicare and Medicaid represent 40% of spending.
Mm-hmm.
Medicare and Medicaid patients account for 60% of cost.
Oh, I did not know that. So that means they're losing money on every Medicaid patient that they take. This is why doctors don't like taking Medicaid.
Well, there's also, I think, another factor here, which is, a common factor of the increasing cost of healthcare, nationally, not just in the United States, but globally, is elder care. Because, you have significant costs at the end of that. And then, you have the reality is in the United States, there's a lot more elderly patients on Medicare, Medicaid than on private health insurance because that the system of health insurance in the United States is generally employer driven, right? So that's a sort of a logical explanation. The concern I have is that if you look at the administrative costs of that system at scale, this is where the problem lies. The NHS system in the UK, which is often criticised, their total administrative cost for administering that type of healthcare is 4%, but in the US system, it's 40%. So,
yeah, I mean, I think I asked ChatGPT what to estimate what percentage of U.S. healthcare is in essence wasted on things like administrative bloat, and then we'll get into the care coordination and medically and socially complex people. And it basically said, about 25%, right?
okay.
So
Well,
so
I'm
one
happy to
one
concede
trillion,
25% instead of
1.25
40.
trillion dollars you're flushing down the toilet through because so what you just got to, Brett, though, was okay, aging of the population. So we're talking about people who are medically and socially complex. So the people in Medicare and Medicaid who are driving like the lion's share of the cost in the system tend to be medically and socially complex, right? And they bounce around the system like beach balls because so I'll give you an example. As part of our product development process, I grew up in the healthcare system, so we can talk about that. But I was at my cousin Anita's vascular surgery center in Phoenix, Arizona, right? And she's letting me talk to their patients as after because they see them regularly after a vascular surgery to see if there's further vascular deterioration, ultrasound them, do all that stuff to prevent, so they can do another procedure if they have to. So I talked to this woman, and she's with her mom, and she's probably in her 50s, and she's on Medicaid, and she had diabetes, and then a surgery that went bad, and she's got like 6 or 8 different doctors, right? 4 years later, and you know, when you look at kind of our website, it says one person, one story, one care plan. So care plan is what you in population health management, right? Which is this data-driven kind of school that's trying to supplant managed care. Um, in population health management, we have this concept of a care plan, which is what are the things that you need to do to stay healthy or to either get back to health or stay healthy, right? If you got a medically complex patient with 6 or 8 different physicians, let alone other kinds of ancillaries, different kinds of service providers like home health, whatever, that person could have 8 different care plans. And
Yeah.
oftentimes the care plans are in conflict.
Yep.
And then boom, the person ends up in the hospital.
Right. You often get prescriptions from different doctors. So you have drugs that we don't even know what the interactions might be, and no one does.
Exactly. Like so her husband, Dr. Venkatesh Ramaya, is, per Newsweek, the number 1 vascular surgeon in the country. And I'm rounding with him at the hospital last week, and he didn't know exactly what what medications one of his patients was taking. Mm-hmm. Right. So, we have data about this, right? So we talked about the one person, one story. Your story is sitting in your data just to eliminate a lot of the, kind of lack of visibility and duplication. Mm-hmm. But the data is all over the place and it's incoherent. It's unusable.
So is this the problem you're trying to solve with Precognitive?
Yeah.
You're going to apply AI to create a customized care plan that looks across all the different caregivers and different programs?
Yeah, I think it's like, so what we say is we're not creating another system, right? Like so our AI is called Reina, for La Reina de Los Angeles, because I suspected that she would take flight in Los Angeles, and she may in fact do that in about 3 weeks. And basically to capture that kind of values that you want to build into AI, right? Things like compassion, care, protection, service, right? Mm-hmm. And what I say to people, so we have a list of like 22 design principles for the product team and the engineering team when we start having a bigger engineering team. And like one of the principles is like, if you're going to create another portal for somebody to go to, they're not going to use it. Right. So the trick isn't to like, it's essentially doing for healthcare and social services what, companies like Plaid did for financial services, right? Where, it's just sort of like, you don't need another system. You need AI is an orchestration and intelligence layer. Mm-hmm. That's starting to knit the system together and creating what amounts to public data infrastructure.
Agreed. So you're building an infrastructure layer of coordination across multiple care providers.
Yeah.
Now, don't you run into HIPAA requirements that your personal health information is restricted in some ways, right? So what can you train the AI on?
Well, the beauty part of it is, I have spent more time over the last year designing her ethical layer, right? But the whole thing is that once the patient gives consent, everything is possible. But the other part of the trick is like, so if I'll give you another story of someone named, I won't use her name, just say her initials were YA. So I worked for a company that does a form of what we're trying to do on a larger scale, what the previous company I worked for, did in terms of pooling hospital data so that you could identify particularly frequent emergency department utilizers in real time and give an emergency, because you're pulling it from multiple hospitals, you can kind of give a doctor or a social worker in the ED, like the picture of what's been going on with this person. So we were launching about 10 years ago in Oakland and Berkeley, and our archetype for designing how this would work at the community level in terms of how other people at different points of care in the community like physician offices, health plans would use it. Our design archetype was named YA. So this woman was like 53 at the time. I think she's passed. PTSD from multiple assaults, including sexual assault on the street, addictions, infectious disease, IV drug use, right? And then she had every chronic condition under the sun: heart disease, lung disease because she smoked, diabetes, all of it, and she's living on the street. This woman was being touched by at least 15 different organizations. Because like Berkeley has its own behavioral or mental health department, whereas the rest of Alameda County has its own. And she was crossing between Oakland and Berkeley and probably taking Barton to San Francisco.
Oh, wow.
And so, so she was being touched by the cops.
Yeah.
Right. Going to jail sometimes, many different hospitals, different
Think
clinics.
about the stress she was under. Oh, man.
And so literally the system was probably, like Santa Clara County did an analysis of like, a small percentage of the homeless population that's chronically homeless. And it was like Santa Clara County, this is 2015, you're spending $200,000 a year in multi-sectoral costs, right, across the whole system, not just the hospitals and healthcare, but social services and jails and everybody.
Yep.
Right. And you're spending $200,000 a year to keep those people on the street. Right. So this woman, YA, all this stuff is being done, and she had at least 8 different care plans, and she still went to the emergency department 350 times in 1 year.
Oh, wow.
Okay.
Practically every day.
Right. Okay. So listen, I want to make sure that we're not going to stigmatize homeless people or disadvantaged people. So let's try to generalize here.
But let's be clear. One of the greatest costs of in terms of later life in the United States is healthcare costs. In fact, there was a statistic, and it's contested, but that 2/3 of all bankruptcies in the United States are due to emergency healthcare situations.
It's certainly true that the leading cause of homelessness in the United States is personal bankruptcies due to medical bills that can't be paid, because the breadwinner gets sick, they lose their insurance, they get sick, they get fired from their job, they lose their insurance, and soon enough the family burns through their savings and they're on the street. So I think that's well established, Brett. But I want to come back to the point I was just making a moment ago before Brett intervened, which is, it's really important, Suneel, that you state clearly that what you're not trying to do is attribute the huge costs and inefficiencies in the American healthcare system due to people who are less advantaged or who are homeless. That would be a bad takeaway from the message you're trying to give us. So help me understand what point you're making.
No, the point I'm making is that the complexity drives a lot of cost, and
a small number of patients consume a lot of services because they happen, for whatever reason, they happen to have a lot of needs, right? Like Brett's point.
Yeah.
A lot of interventions happen in the very later stages of life, right? So very elderly patients also rack up huge healthcare costs, and that can be a burden to their families. Even if they pass away, they're still saddled with those costs. So we have some situations where a small number of people are going to use a lot of healthcare. Is that correct? I think I got that.
That's the whole thing, that so the whole science and art, it's more of an art still 20 years later than it is a science of population health management. Which and so the construct we're trying to enable is called value-based care as opposed to managed care.
Mm-hmm.
And and it's basically starting to pay for outcomes rather than for procedures. And so the whole essence of it is, can we use data to find that 5 or 15% that is showing up 50 to 75% of the cost, and then mobilize.
Okay, but when you talk about value-based care, you could point to people who are using the GLP-1 inhibitors right now, because that's a very expensive drug to use. Those people are perfectly healthy people. They're just trying to lose weight, or they're using it for some other reason. So it's not simply disadvantaged people or homeless people or elderly people. That's affecting. There's a lot of people then in the system who are, I guess, taking more than their fair share. And the problem is, managed care approaches this as an average, so everybody gets an average amount. And you're trying to create a more personalized approach. Is that correct, Suneel? I'm trying to triangulate on what you're actually doing in your current startup.
So the reason we named the company Precognitive, right? Minority Report. That's a cautionary tale. Don't take that as inspiration. But the whole idea is that ultimately, okay, so what's really going on with these people typically, and they do tend to be either people with serious mental illness who are disproportionately, Black, right? And I mean that health equity is a huge issue in this country. And because it's driving a lot of
Yeah.
this cost needlessly. And it's not even about the cost, it's about the shattered and wasted lives, right? My brother was seriously mental. I'm trying to stay away from personal stories. My brother was seriously mentally ill. He died in a state mental facility or a state psychiatric facility in California at age 60, right after. And he bounced around the system. Like the reason I was getting into that is if you're going to have a comprehensive view of people, it's not just the healthcare system. You got to include data from the jails, right? You got to include data from like social services and homeless shelters that they're hitting, so that we understand what's going on with them. So now we can mobilize a response, right? So hopefully I didn't just go down a rabbit hole that you weren't trying to. Did I answer? I don't think I answered your question. Restate your question.
I mean, I guess I'd say, what's the business of Precognitive? Who's the customer, and what service do you provide?
So our initial customers that we're really focusing on. So our business and policy case is really rooted in, so if you think the increase in premiums is bad now, it's going to get much worse as Medicaid gets the $1 trillion in cuts that are coming over 10 years, right? Because then the reimbursements in Medicaid are going to go down even more. And that's going to wash up more in your all of our premiums again, right? You're paying twice. You're paying through your taxes, and you're paying kind of an invisible tax in the healthcare system shifting costs. And by the way, this is not everybody accepts the cost shifting argument, but it's kind of intuitive to me because I've looked at Pareto analyses of hospital finances. So let me give you an example, right? Okay, so this gets to the problem we're trying to solve. I went into one hospital system and looked at two of their hospitals, in an urban area that are part of one medical center. I said to an electronic health record analyst, run me a Pareto distribution of your patient population and do it by payer category, right? Tell me like overall, Medicare, Medicaid, and commercial, right? And so I said, and just basically your, top, how many people are in the top one, cost percentile? What's their utilization? 3 to 5, whatever, right? And basically what we found was that, the key unit of cost for a hospital is a bed day. So on average, U.S. hospitals, their cost per bed day is $5,000 or $6,000. So what we found was that of the 34,000 Medicaid, which is called Medi-Cal in California, that had gone to those two facilities over a year, about 1,200 of those people, or about 3.5%, accounted for 55% of their bed days. And that hospital system then in 2025 dollars lost about $80 million. And then that hospital and system in turn loses about $800 million a year that it's then having to shift onto you, right? Or onto us in terms of our costs. So the problem we're trying to, and the reason, so the real issue is people who go into the hospital and they stay just a long time. They don't necessarily go to the hospital a lot, but when they do, they stay in. And the reason they stay in is in some cases, like with that woman who I met last week in my cousin's office, she developed a severe infection from a medical procedure that went wrong. And she goes in the hospital with an infection and she stays there for 3 months. But a lot of other people, they're just staying there because you can't step them down. You don't have a place to send them to in the system because the system's like log jammed. I can't get them to a skilled nursing facility, which is a cheaper setting. If they're a homeless person, and I'm not stigmatizing the homeless, a lot of my work over the last 10 years is about doing better by the homeless, right? Because I have a lot of compassion for those folks. Because a lot of them, it's the people who end up chronically homeless and costing the system a lot. A lot of it is mental illness as a function of childhood trauma,
Right? Yeah.
Right. And so basically, what we're trying to solve is hospitals' problems around throughput, so we can target those highest utilizers and get them out of the hospital more quickly. And to do that, you got to improve processes in the hospital, but then you have to create networks in the community to both take them, right, and provide the services they need, make sure that the connections happen, and keep them out. That's what our AI is initially really targeting to do. And you have to do it, if you really want to do it effectively, you have to do it that comprehensively.
I like this directionality. I think we're obviously going to see a massive transformation in healthcare over the next 20 years. Even just today with incredible improvements in diagnostic capability, being able to understand, and identify the problem more quickly. That's going to result in improved treatment. We've got gene therapy as a potential strategy over the next decade, where certain diseases that we have, chronic diseases, can be taken, removed from our DNA software like a bug, within some reason. So we've got some incredible tools that are emerging here. But I think the overall problem I get in terms of the discussion you're having is that this system is not designed to dispense care in the most efficient manner. In fact,
Right.
what we've got, what you're describing here, is a system that's designed to monetize healthcare, not designed to be the most efficient solution platform. How do we shift away from that? Because that's the key criticism I have of the US healthcare system. It's a health profitability system, not a
Yeah, they're
healthcare
running it
system,
like a
ultimately.
business. They're running it for
Yeah.
profit, which
Well,
means by definition they're going to give you less service for the money, right? That's the way they make a profit.
well, I mean, it's kind of the incentives vary across the system and by the kind of the type of organization you're dealing with. Like, for instance, the distinction between a nonprofit or a for-profit organization, right? So LA Care, for instance, which is the largest local initiative Medicaid plan in the United States of Los Angeles, right, and 2.8 million members, is essentially it's a quasi governmental entity, right? So they're not necessarily, but what I would say is that I think the way I see the problem is that we're the victims of our own success. Like with my parents and their medical practice in Yucca Valley, California, in the 1970s and 80s and 90s, people died off at like 70 or 72 or 74, right? Because people, I mean, what's one of the biggest public health advancement in the last 30 years is basically nobody smokes anymore.
Mm-hmm.
Right. So you've just taken out, chronic obstructive pulmonary disease is a big category of illness. And now we have all sorts of ways to treat heart disease.
Mm.
Right. And GLP-1s are a huge public health advancement because you're going to see less chronic disease, but it's going to get washed out to a degree because people are just going to live longer and they'll just develop stuff later. Right.
Mm-hmm.
But
Right. Eventually the machine wears out and then you're going to have a chronic health problem.
So I kind of had this inspiration 14 years ago, and because I'd worked in a field called remote patient monitoring, which is basically about how to use home-based technologies primarily for the daily management of chronic disease, right?
Mm-hmm.
I mean, you could look at my Oura ring and say like that's a device for the for consistent or for the prevention of of chronic illness, right? And this stuff was really, really effective, right? Like Medicare was doing demonstration projects during the 2000s around chronic disease management because at this point they were going like, yeah, chronic disease accounts for 76% of our healthcare spending, right? So we got to do a much better job of managing it. And so, we ran a project where I was working for a technology company. We got a couple of medical groups in the Pacific Northwest, and we had co-developed our technology with the VA, right? Where people who have, are medically and socially complex, often with mental illness, put devices in their homes and basically, ask them a bunch of questions every day, like about, what are your vital signs and symptoms, and what are your, are you taking your meds? Are you eating properly? And, what do you understand about your condition? And it was really effective. And so then we did it again with Medicare, and we had like the most successful project of the many Medicare ran during the 2000s. So I saw the success we had with that program. And then I'm like, doing a project for the Gary and Mary West Foundation down in San Diego. They're these really wonderful people who funded a bunch of stuff, particularly in the aging space and around reducing healthcare costs. And so I'm on a project for them about how we would use technology to support people who go to this senior center that they funded in downtown San Diego. And I'm on a plane and I'm watching the movie The Social Network, and I'm watching, Jesse Eisenberg or whatever playing Mark Zuckerberg, and his face is like Facebook is first lighting up at Harvard.
Mm-hmm.
Like, why couldn't we do that with healthcare and social services and just do a social network, right? To enable the system to act more like a system. So I'm kind of now just carrying that kind of spirit forward because now we're in AI. Like we were doing amazing things with chronic disease management, and we all kind of ended up realizing it wasn't about the disease, it was about the person, right?
Mm-hmm.
And a big element we did is like pre-AI simulation of social support. So there's that element, but we didn't really support care coordination. And so if you ask ChatGPT, the system loses $200 billion a year just because of the breakdowns, right, in getting people connected to the services they need. So we're kind of solving
got
for
that.
that.
Okay. Yes, we're covering stuff that you mentioned earlier, and I get it. There's a way that AI can help facilitate better coordination across different healthcare providers. Let's go to break now because we're running a little late. So Suneel is our guest, Suneel Ratan from Precognitive, and you're listening to The Futurists. Stay tuned because we're going to be right back after this message from our sponsor.
Provoke Media is proud to sponsor, produce, and support the Futurist podcast. Provoke.fm is a global podcast network and content creation company with the world's leading fintech podcast and radio show, Breaking Banks. And of course, its spin-off podcast, Breaking Banks Europe, Breaking Banks Asia Pacific. But we also produce the official Finovate podcast, Tech on Reg, and Emerge Everywhere, the podcast of the Financial Health Network. For information about all our podcasts, go to provoke.fm or check out Breaking Banks, the world's #1 fintech podcast and radio show.
Hey, welcome back to The Futurists. I'm Rob Tersick with my co-host Brett King, and this week we're talking to Suneel Ratan. And Suneel is running a company called Precognitive. He's been giving us some interesting and, to my mind, insightful perspectives, things I was not aware of, about the many, many failings in our ultra-complex healthcare system. Hey, Brett, you're a global traveler, and one of the benefits of doing that is that you get to see the world through a lens that most people don't, which is that you get to experience it firsthand as you travel around the world. What's different about American healthcare? Most of the countries in the world do have some form of universal healthcare. It might not be as comprehensive as we'd hoped, but certainly of the industrialized nations in the Northern Hemisphere, all of them, except the United States, have some form of universal healthcare. What's the story with that? Can you tell us what that experience is like and how it's different from what you might get in the U.S.?
Well, again, I've lived in the United States. I've paid U.S. healthcare, and I'm now living between Dubai and Bangkok, and I have private healthcare there. Although in both of those instances, they have very good universal healthcare systems. I mean, you see this meme a lot on social media, that universal healthcare is so difficult that only 36 of the world's 37 developed nations have solved the problem, right? And that the US is the outlier. The concern, Sunil, that I have with the conversation that we had in the first half of the show is that a lot of the problems that we see and where the costs are being incurred and the problem that we have to fix, I think it's a core structural. I don't know whether it's a problem in the Constitution or core economic thesis of the United States, but in these other developed economies, we accept that the cost of providing social care and healthcare to people that are otherwise affected, with these chronic situations that you've described, that is a basic core cost of the economy. Universal healthcare is a basic human right in these economies.
It's a public
That is
good,
not
right? Everybody wants to have a healthy population, so it makes sense to invest in keeping people healthy, keeping them outside of the healthcare system.
That's not the position in the United States, right? So I mean, that seems to be a core part of the problem. So how do we, is there a path to solution? I'm not talking about bipartisan politics here, but what's the technological part to resolving this, where we can provide this level of care across the economy without having to have this sort of conversation of whether healthcare should be a basic human right instead of a profitability engine?
Well, I mean, I wasn't trying to blame the victim when I was talking about homeless folks, because part of the point I'm trying to make is that we've been in this vicious cycle in the United States where we underinvest in communities, and then people get sicker, and then they go to the hospital where they're getting a lot of high cost care. And in a lot of the other countries, the insurance system, everybody who actually has to deliver care in the United States will say that the insurance system is a huge problem.
Mm-hmm.
Right? The cost shifting between the systems, the amount of administrative expense, all of it. We may, in fact, without me, I'm not making a political statement here, just from a futurist perspective, you're kind of going to back into Medicare for all. Right, because the system's just kind of unraveling.
Well, we have it. It's just that it's not called that, right? So in the United States, hospitals cannot cannot reject somebody who comes in, even if they don't have insurance. They have to provide them care.
Correct. Correct.
And in the United States, we don't have universal healthcare. So some people who are coming to the hospital are there because they don't have healthcare. It's not a very big percentage, but they don't have healthcare. So then they don't get the routine treatment that they need, the routine care. In other words, they only come in when it's acute, when they have a crisis. And so they go to the emergency room, which is by far the most expensive way to deal with the problem, right? Prevention would be better, management would be better, staying fit, staying out of the healthcare system in any way you can would be better than showing up at the emergency room. And when they do show up at the emergency room, since they can't afford to pay that bill, that bill has to be then spread across all the other folks. And that's why in the United States, people don't often notice this, but we spend $500 billion on drugs, and people complain about the profits of pharma companies. And we're often often thinking of pharmaceutical companies as the villains in this. But that's $500 billion. We spend 1.5 trillion on hospitals. And meanwhile, hospitals are closing. Rural hospitals are closing. They're cutting back services and care and so forth. So what's happening is this kind of consolidation into these large vertically integrated care companies that often have a hospital, but they also own like doctors' clinics, other treatment centers, diagnostic centers, and so forth. So our healthcare laws have created these kind of vertical enterprises, which are there. Face it, they're private companies. They're there to profit maximize. They have to. They're not very profitable because, to Brett's point in the first half, they're incredibly inefficient. And this is the part that we don't understand or examine enough.
So you asked earlier, like, who are our initial customers or health systems? And what we're doing for them is in effect automating a lot of the processes that are driving, so you're familiar with the term Baumol's cost disease, right? About how in labor-intensive, typically public sector services costs inexorably rise because just labor costs. You can't improve the productivity of people, and our labor costs keep going up in excess of inflation, right? So we got to start using AI to just radically improve the productivity of those people, right? So you talk to Ella Schwartz, at Sutter Ultimate Summit Medical Center, and there's so much friction in her day, right? Trying to get services authorized by insurance companies, trying to arrange stuff for people. And we can use AI to just start automating a lot of that stuff.
Yeah.
It really is astonishing to me how inefficient the system is. I'll give you an example. So I just recently had a medical procedure just last week. It was a routine procedure. It was no big deal. But I had to get pre-authorization twice, not one time. The setting up my account took forever. I had to fill out the same paperwork 4 different times. It's all on paper. They say, well, you can send us a fax. And I tell them, I don't have a fax machine where I live. They don't have fax machines. And they say, where do you live? And I say, I live in the 21st century, for crying out loud. Nobody uses fax machines anymore. It's absurd. But that's because you're not allowed, because of our HIPAA laws, our health privacy laws, you're not allowed to use digital services to send the data. So you can't send an email to your doctor. You can call. If you call, you're going to call 25 times before they pick up the phone, and then they're going to put you on hold for an hour, and you're going to get disconnected. I mean, this is literally the experience I just had last week. So you have to fight for every kind of care that you get. No wonder people drop out of the system. And when your premiums get jacked up to $35,000 per family, guess what? A lot of healthy families are going to drop out. And that means, Suneel, the problem you described earlier, that the unhealthy people are in the system, the people with the biggest needs are in the system. The healthy people are going to be dropping out of the system. I think younger people are going to drop out because the price is so high. Your people are going to make a calculated guess, and they're going to say, gee, I'm going to bet on my health, and I'm not going to bet on shoddy services that are overpriced. So the pool is going to shrink. Now, this is a really serious like death spiral, right, for the U.S. healthcare. And I think the problem I'm describing isn't entirely theoretical. I think we're about to see it happen in the United States. Go ahead, Suneel. I'm talking too much. Go ahead and respond.
Because I should have done a better job as a former reporter teasing out your lived experience too. So I apologize for that. But
you're not here to interview me. It's fine. You're doing great.
I'm always here to interview people. So think about one of the costs that isn't on the books is that going to people, particularly like families with older adults, right, who are declining. So there are 63 million family caregivers in the United States. According to statistics, they spend on average 24 hours a week caring for their elders. Mm-hmm. So that's an additional $1.5 trillion of cost that's not on the books, in addition to the $5 trillion we're already spending on healthcare. Mm-hmm. And so people, that costs people their jobs, right? Because they're having to care for somebody. especially if you've got two parents,
Hmm.
right, that are both declining, it's going to affect your job. It's going to affect your family life. It's going to affect everything. Right. So this is all the stuff that we can use if we have kind of AI that's starting to knit this. And what do they spend a lot of their time on? Just the stuff you talked about. Right. It's like
Filling out paperwork.
every time I go to a new doctor, I have to fill out an assessment because they have no prior visibility on my story. It's like,
Yeah.
okay, we're going to have Raina and carry your story around with you. And so you don't have to fill out a new assessment, right? It's
Yeah.
just like, I'm going to share with Raina.
Yeah.
And then
Scan this QR code. There, done. Here's my data.
just use Raina, and Raina has your story because Raina's sitting on top of all the other data sources, right? And we know how to make this work under HIPAA, right? Because
Yeah.
ultimately, you give us consent, we can get your data, right? And notice I said story, not your data, right? Because what we need to start also doing is turning all of this data into more meaning, right? You can appreciate this as a former media or as a media person.
There's another problem we run into here, which is that even the way we store data in the healthcare industry here in the United States is we're subject to proprietary standards by private companies that are monopolies, that are extractive. So even that's an inefficiency. The way we handle data between the hospitals and between caregivers, you have to go through a company. And I mean, across the board, you see these inefficiencies, but that's one of the reasons why we're having to manually enter the document, the information by hand.
Right. So I've been down in the guts of the data plumbing and built, being one of the people that built out the data plumbing for interoperability over the last 10 years. So like one of our partners is this great company called Health Roads, and they've built this application where they can take data from multiple data sources, normalize it, and then essentially turn it into something coherent, and then denormalize it so it can be pushed back into the different systems of record in a way that will then drive meaningful action by providers, because they'll have the whole picture. Does that make sense?
But would Epic allow that? Because Epic is the dominant provider of healthcare data, right? They're the manager of healthcare data, and they operate a proprietary standard. It's not an open standard. Other companies can't compete on that standard. I would suspect that in their terms of use, they prohibit the very kind of translation that you're talking about.
They can't do that anymore under so my former boss of Collective Medical, which is a company, he now runs Medicare, Chris Klomp, wonderful guy. And CMS or Medicare, the Centers for Medicare and Medicaid Services, and then other organizations in HHS, and this has been consistent between administrations, have really been pushing interoperability, and you can't block data anymore. Epic can't do that, right? And our whole business at Collective was like taking data from different hospitals, like Epic hospitals and Cerner hospitals and Meditech hospitals, all the different EHR platforms, and a lot of our secret sauce was like we could normalize that.
Okay,
right.
So when we're talking about EHR, those are electronic health records.
Yeah.
It is a highly contentious topic inside of the healthcare industry because the data that we're describing is basically a proprietary data asset stored in a proprietary format, controlled by one of those companies. And you're saying now that those data monopolies are being undone by some legislature.
Yeah, I mean there are health information exchanges all over the country. California has created what is called the data exchange framework. So pretty much every provider in the state has to provide its data.
Okay. Hey, let me shift to another topic. So when I lived in Canada, I want to just underscore a point that Brett made a moment ago. So not too long ago, I lived in Canada, and when I was there, if you needed healthcare, let's say you felt you had the flu, you'd walk down the street to a clinic. There's clinics all over. You'd walk into the clinic. You didn't need an appointment. You might have to wait 15 or 20 minutes because you're walking in. And you'd see a doctor, you'd present your card, and the doctor would say, you've got the flu, and here's a prescription. It would take about 15 minutes. You walk down the street to a drugstore, show your card, and you got the drugs. I didn't have to pay for anything. And I had medical procedures. I had to get an MRI for an injury. And I walked in, the Vancouver hospital had a price list, including the price of an MRI. It was posted publicly where you could see it. And that was the price that you had to pay. And fortunately, at that time, I had travel insurance, so that was 100% covered because of that. What I just described is like science fiction to Americans. That scenario I just described is like science fiction. And you're right, Suneel, to defend Kaiser Permanente, that's one of the early health management organizations, and they're trying to provide something like that. If you're a member of Kaiser, then you can call and get an appointment. You might not get your doctor because they're never available, but you would get another doctor, and then that person could see you probably on the day you need to get seen. And then you would go to the Kaiser-owned pharmacy to get your drugs. You'd still have a copay along the way, so it'd be $35 each time, or something like that, each step of the way, and some copay for the drugs. But it's similar enough to that Canadian example that I just gave, And the point there is, I'm not filling out paperwork. I'm not asking for a pre-authorization. I don't need permission from some private sector middleman. I don't have to ask the finance department whether what my doctor prescribes for me is something I medically need or not. I don't have to justify my needs. I just go show the card and get the treatment that I need. I think this is what people want, although Americans can't always articulate that because they haven't had an experience of it. Instead, what we get is the same way that other large organizations deal with customer care. These big organizations will keep you on hold knowing that a certain number of people are going to drop off the call because they have to go to work or they have something else to do. So like it's poor service by design to get you to attrit away out of the system and not use the services that you're paying for. That at least is my impression. I'm no healthcare expert, but I am a user of healthcare here. I've also experienced healthcare in the UK and in Finland and in other countries. And I have to say, in generally, often what you hear in the United States is that the healthcare services in the U.S. are the best in the world. Other countries don't come near. That's just not true. That statement is categorically false. The healthcare treatment I've gotten in a number of other countries is at least as good as the United States, and it comes with a lot less friction and a lot less process. That's one of the reasons why it's cheaper.
Yeah,
because you're not paying for it. I think Americans don't realize when we pay a private healthcare company for insurance coverage, what you're effectively paying for is the people who deny your claims. You're paying the salaries of the people that you're going to be on the phone with begging when you want to get coverage, because that's what the premiums are paying for.
Well, I think let's talk about how we could evolve the system. First of all, you are going to have a massive structural change around healthcare in the middle of next decade, because longevity treatments and gene therapy are going to start to be mature. So you're going to have a shift to much more proactive, data-driven healthcare.
And
These sort of
personalized healthcare.
and this sort of absolutely, and this sort of siloed, corporatized approach is just not going to work. So we've got 10 years to completely transform the way US healthcare systems work. And if you keep it in this sort of privatized oligopoly world, the US, the level of US healthcare comparative to these other systems where there's very strong incentive to create autonomous systems and better diagnostics and all of that, because it's a national cost. Those systems are going to become significantly more efficient faster, and just the same as what we've got with the energy system in the US right now in terms of transformation. It's going to be halted by this sort of this lobbying infrastructure that's there. How do we get a really smart personalized healthcare system driven by data that's going to give everyone better care in the United States? That's the question, Sunil.
Go, Sunil.
So I think, well, I mean, just at a most basic level, with what Robert just described in his experience about being in Canada and having the flu. I mean, you're 3 to 4 years, if that, away from like your health system having an agentic AI front end that can triage, not to minimize the flu, right? But it's lower level than saying, having cancer, right? You don't necessarily want an AI pseudo clinician kind of triaging you and saying like, oh yeah, you have the flu. Here's your prescription, and it's waiting at the pharmacy. But that's going to be a part of it.
Yeah.
Now,
in China, by the way, that's already the case, right? So in China, Pinyin is a big insurance company, and they now have these booths that you can go to. They're little AI booths. It's a private booth, and you go inside and you talk to the AI, and it can actually vend 100 different medications in that booth. It's actually kind of a cool thing. It's like a little healthcare kiosk.
Exactly.
And, of course, you're not going to go there if you have, if you're bleeding or you've got a wound or a broken leg. I'm not trying to be fanciful about it, but most of what most people need most of the time is pretty routine. I mean, even in the U.S., the evidence of that is you can get treatment today on a video call, a technology that I had a hand in innovating 20 years ago, but now it's actually quite common in the U.S. to use the app on your phone to talk to a doctor. So that's, how far are we from an AI being on the other end of that call? Why does it have to be a human being? And how can you even tell with deep fakes it might be today?
I would say hopefully this isn't orthogonal to what you just asked, but so when we were working with the remote patient monitoring technology that we were doing, back in the 2000s, right? And then it's a longer discussion as to why that company no longer exists, right? Even though we were so successful in demonstrating outcomes. So we're like handling older adults in Medicare in their homes, and it's kind of like a digital pre-AI projection of a care manager in a clinical setting. And, basically we're touching a person every day. And one of the so I asked the founder, because we reconnected, Steve Brown, another doctor's kid, and I said, Steve, why do you think what we did worked? And he goes, oh, it's because we simulated social support, right?
Mm.
Okay, that's one of the big takeaways here is you're saying that the problem starts upstream. It starts with social support and the lack or the absence of it in the U.S. It means the medical outcomes or healthcare outcomes on the other end are going to be much more dire.
Yeah,
You can nip it in the bud with social support. That's sort of the drift of what you're saying.
well, I think a lot of chronic diseases are diseases of privation and disconnection.
Yeah,
So like,
sure.
so you want to, okay, so why did 82-year-old woman with heart disease, why did she go to the hospital? Well, it's because her daughter didn't call her for 3 days, and then she felt lonely, so she had a beer and a roast beef sandwich with a lot of mayonnaise at 9 o'clock, and lo and behold, the next day she's feeling like she's suffocated, and all of a sudden she's off to the hospital. So somebody had touched her, right? Like, leave aside AI. I have a friend who's doing a service where they just have people, just lay people calling people in high risk, kind of health segments, like every week, to provide social support. And they in a high risk pregnancy segment, they reduced the percentage of preterm births from 13 to 5%, right? And preterm births often will lead a newborn into a really expensive episode in the NICU, right?
Mm-hmm.
So that's kind of how I'm not going to make political statements. We can talk all day about make America healthy again, but a big part of it is there is the food supply and cleaning that up. We can all agree with that, right? But
Sure.
just get people connected again, right?
So Neil, in the moment that we have left, I want you to respond to what Brett was saying a moment ago about all the places where we might apply AI. What does healthcare look like in 2050 in the United States?
Well, I think there's a big push by Medicare to move care to the home, and technology is going to be a part of that, right? Like I was looking at something and I sent it to my co-founder Terry a couple of weeks ago, where somebody was at a conference who's pretty knowledgeable and said that in 10 years 90% of care is going to be delivered in the home. So I think you're going to be looking at more care that's via AI and other supportive technologies has been pushed to the home, including elder care, right? Like, and then I think you're going to see that through AI, the system behaves more like a cohesive system, because right now it's not, right? It's a fragmented mess. In California, I'm a Californian. I respect the government of California. I think it's done a lot, but it's a fragmented mess. So it's like somebody go to ChatGPT and go like, okay, understanding that change is hard, right? And you got to start where you are, right? Like there's no, for all the reasons we know, short of an epic collapse, we're not going to legislate the current insurance system out of existence, right? So how do I use AI just to start rationalizing all this stuff?
And that's interesting. So when you say rationalize, of course, the word I hear, or someone else might hear, is ration.
No, make coherent and consistent. But so here's an example, and it goes back to what Brett was saying too, is part of pushing care to the home is exactly that example I used, right? So that if I don't have humans to do it, I automate, via AI what amounts to social support for people. And then I'm touching them every day. And rather than them having to come into the office like every 30 days or 60 days because they have a chronic illness, I only have to see them when they actually run into trouble, because the AI has basically said, like, you need to call this person, you need to get them into the office right now. And that's what care starts to look like. And
what does it mean to deliver healthcare in the home? Is that me injecting myself with something? Is it me doing surgery on myself? Is there a little robot driving over to my house to perform that surgery? Like, when you say that, what does it look like?
Well, no, but even, it's, my mom and dad, my dad was a cardiovascular surgeon. There's no way he could have done what my cousins Venkat and Anita are doing, right? Where they do vascular surgery in the office now, right? For people who are more medically complex and older, they still do the procedures in the hospital, and people who are less medically complex. So you're going to see a lot of those services increasingly be able to be transferred to outpatient settings. But no, you're not going to get surgery in your home. There's not going to be surgery bots. I can't see that by 2050. Would you want that?
No, but no. Well, I mean, I think so. I think, but I think you could have. I think what would be applicable is that you could have a personalized supplement and medication delivery system
Oh, totally. Yeah.
And you'll have a data system that will be monitoring your health 24/7, and
Right.
you will know, like, so you won't go to the doctor because you've got a symptom. You'll go to the doctor because you've got some sort of imbalance that can't be dealt with by the autonomous system.
Bing, bing, bing,
Yeah,
bing, bing.
that's how I think of it, right?
Yeah. And AI will have rationalized a lot of the administrative complexity away. And we got to be frank about what that means, right? People are going to lose their jobs. I'm not a big fan of AI just going and taking. I'm like for compassionate, human focused AI, not AI is like we don't really know what the use case is, except like this is sometimes when I hear and then you read Empire of AI and it's sort of like the use case is we're going to take all your jobs and then maybe kill you. Right? No, let's be conscious about what we're designing for. So I'm concerned about the job loss, but I don't know what to do about it because it does represent a lot of administrative expense that may be needless, right? That's not being incurred in other countries. So
Yeah, I think
their social
I think
use.
there's a lot of people working in administrative functions right now that are doing what David Graeber would call bullshit jobs. An example, something you see in U.S. clinics that you don't see in clinics in other countries, is when you walk in the front, the waiting room area. There's a desk, and behind it there'll be 6 or 7 people on computer screens, and they are not there as receptionists. They're not there to help you. They're there to contend with insurance companies, and they're trying to get paid. That's all they're doing. So that's like an extra layer of cost that every doctor's clinic in the country has to have as a full-time staff that is just there to contend with managed care and get paid.
Yeah.
That's incredible inefficiency. If there's a way to get rid of that, well, by all means, let's automate those jobs out of existence.
Yeah, because like our first, like you really want to start with something very simple and focused. So our first product or the first instantiation and representation of RAINA is basically a RAINA clinical summary that brings together all the data about you
Great.
and gives a concise summary. And an interesting dimension of what that can be used for is a medical necessity determination for prior authorization,
Mm-hmm.
right? But so what does that eliminate for Anita? Right now to do that, she has like someone in India who's literally cutting and pasting from other systems every day into her electronic health record system to give her the full picture. Yeah, that person's not going to have them go do something else that's more valuable, right?
Yeah.
But I think that's where we start is like use AI just to make people's experience, and that includes anybody, whether they're in a professional or in a personal setting, just make it easier for them to do what they need to do. Like another example is I've gotten 2 cardiology referrals, preventively from my primary care doctor in last year. Why haven't I done it? Because it was on paper and now they expect me to go call them, right? And I know what a miserable experience that is, so I haven't done it.
Mm-hmm.
Use AI to just automate the referral.
I agree. This obsession with filling out paper forms and using fax machines and getting on the phone. These are the ways you get to talk to the healthcare industry in the United States, and they're all super inefficient. I don't mean to be terribly contentious, but I'm going to throw a terribly contentious question at you right now because, Suneel, you just mentioned the prospect of artificial intelligence automating your healthcare records such that the AI might be able to help you determine if a procedure is medically necessary. And that sounds good to the extent that it means I don't have to deal with a wall of paper and a bunch of bureaucrats. That sounds good. But that leads me to conclude that some populist out there is going to turn that around and say AI death panels, because the AI is going to handle the rationing and the AI is going to determine who gets care and who doesn't. Deal with that one.
Well, the other thing I would add to that is that, look, at the end of the day, I mean, we go in from a futurist perspective, right? You kind of look at historical cycles, and in the United States, they tend to run in 90-year cycles. And clearly the cycle that started in the Great Depression and World War II, and, the industrial economy, and then, broadcast television, and then, and so, I think what AI is in data increasingly enables us to do is to go for outcomes-based care rather than process-based care. So, and the AI can basically say, like, will this achieve the outcome in terms of, but I think what you're speaking to is like part of our new era. We've moved. The other thing is like, the internet happened in 1994 and 1995, or the broad-based internet with the advent of Mosaic, right? And you all of a sudden, started to shift radically from a hierarchy-based world to a network one, right? But our systems have never caught up to that. And so you have social networks, but you never had an explicit social compact, let alone, law or regulation, or whatever you want to call it, just about kind of, I think we have to, part of this is kind of how do we enable or leverage AI to kind of infuse things like trust and compassion back into our system. So it isn't about process or profit or all of that all the time, because I think it's depressing, right?
That's the most optimistic thing anyone said on the show about AI in the last 6 months.
Well, you have to
The idea that AI is going to infuse compassion back into the system. I love it. Let's
that's
hope
why
that's true.
that's why
Very
we named,
optimistic scenario.
well, that's why we named our AI Reina, right? Because she's your guardian angel,
Ah,
right? And so if you, the way to have
That
a
makes
safety
sense.
net is to have a AI guardian angel, right? I mean, it's kind of like that book Imperial Earth. Have you ever read the book Imperial Earth?
so it's like it's like agentic healthcare. This is your personal AI advocate. That's how you're framing it.
Yeah, and then once you've wired up, like if we go viral across Los Angeles County, the use cases multiply, right?
Mhm.
Because like, okay, so you're in Altadena, the winds are whipping at 100 miles an hour, and then Raina's telling you like, you need to get out of your house now. This is what you need to have in your go bag, and this is where I've arranged lodging for you over here. Right, that's the kind of that's ultimately, once you've got these kind of comprehensive networks, because they need to be comprehensive, that's the kind of stuff you can start to enable, and it needs to be considered public infrastructure, and the people building it need to carry and shoulder the responsibility of it being public infrastructure, right? We're not doing Facebook here. It's almost like I don't want to dump on Facebook.
No, it's all good. So we're going to bring the show to an end. It's been an interesting conversation, and I'm thrilled Brett was able to join us for this. So,
Yeah.
folks, you've been listening to The Futurists with Suneel Ratan. He is the CEO of a new company called Precognitive that is building AI agents for your personal healthcare. Suneel, where can people learn more about you and Precognitive?
Our website, thank you for that, is precog, PRECOG.works. WORKS.
Precog works.
Precog.works.
Okay, cool. Well, thanks for joining us on The Futurists. Brett, great to see you. And folks, if you're listening, every week we will bring you another person who is future-minded, who is thinking about and actively working to shape or influence the future. We welcome that. We'll be back next week with another guest who's working on similar things. And of course, until then, Brett, over to you. Until then, we'll see you.
See you in the future.
Well, that's it for The Futurists this week. If you like the show, we sure hope you did. Please subscribe and share it with the people in your community. And don't forget to leave us a 5-star review. That really helps other people find the show. And you can ping us anytime on Instagram and Twitter at Futurist Podcast for the folks that you'd like to see on the show or the questions that you'd like us to ask. Thanks for joining. And as always, we'll see you in the future.